Why this is because blood has many side effects. So this is one important thing. So we always try to do something called transfusion-free transfusion medicine. So the three pillars of this include detection and management of anemia and iron deficiency early, minimization of blood loss and optimization of coagulation during and later on also leveraging and optimizing the patient specific physiological tolerance of anemia. So even if patient has some anemia, if he is able to tolerate, there is no need for transfusion. So I'll go into more of this. Any surgery, especially pertaining to cardiac surgery, there are many risks. For example, some procedures will have higher bleeding risk, especially redo cardiac surgeries. There will be some patient specific factors and general risk factors as described here. It can be high age, coagulopathy, patient having multiple anastomosis. So all these will definitely affect the blood transfusion requirement for any patient. Now if we see, there are multiple criteria to say a patient may require or a patient may have perioperative bleeding, which may be somewhere between class 0 to class 4. So these are multiple definitions. And if we have to categorize what level of perioperative bleeding a patient has, then the worst case scenario has to be taken. Like for example, if patient is requiring RF7A, it means it's directly a class 4 massive perioperative bleeding. And why I am discussing regarding this perioperative bleeding is, if patient is having more blood loss, they will obviously require more number of units. So here we can see this is a study by Petro. So class 1 and class 2, they have clubbed together here. So patients who take less than 10 units during their surgeries, they have far better chance of survival. While the patients who are having more than 10 blood products or blood units transfused, they have highest chance of mortality. So this is why we try to avoid blood transfusion as much as possible, and we try to take so many measures. So this is one more latest guideline from transfusion medicine. So we try to do something called ROTEM test protocol. Usually people who have TEG, these are all point of care tests. So TEG is there, but we feel more comfortable with ROTEM because we can manipulate the ROTEM with different kinds of modifications. So this is one important thing. We try to transfuse patients depending on what characteristics the patient has in ROTEM. For example, immediately after a surgery, we try to check the clotting time in INTEM. INTEM means it's intrinsic pathway thromboelastometry. So if it is more than 240 seconds, it means that heparin, deheparinization or protamine is not sufficient. We haven't given sufficient amount of protamine, so we try to give protamine. If the maximum clot firmness is less than 9 mm, that is in FibTEM. FibTEM means fibrinogen thromboelastometry. We try to give them cryoprecipitate. Now fibrinogen concentrates are also available at lowest price, so we can use those also. And similarly, this is the protocol. This protocol is maybe useful for CT surgeons only. This cannot be used for maybe, for example, PPH patients may not be useful this protocol, because each and every category is different. So there are different protocols for different kinds of patients. ICU categories, ICU protocol is different, the protocol for neurotrauma is different, PPH protocols are different. This is for cardiac intervention. So similarly, we try to administer patients with platelets when the FibTEM is normal, but the amplitude at 10 minutes in extrinsic thromboelastometry is less than 40. So it means that platelets are not functioning. Maybe it can be due to various reasons. So this is one simple indicator. And last but not the least, if there is hyperfibrinolysis, we try to give them tranexamic acid. These are the guidelines actually from European Association of Cardiothoracic Surgeons. This was published this year only. So they suggest this protocol. So before admission only, we have to try to identify anemia, its causes actually, and manage the patient before we plan them for surgery. And pre-op also we have to do many tests, like for example, guideline directed management of antithrombotic medication, patient function testing is there. I'll go into these. So In addition to that, platelet function testing in patients, especially on dual antiplatelet therapy, is required. Fibrinogen testing is also required. So the recommendations are checking pre-op hemoglobin levels, then oral IV iron therapy, erythropoietin requirement may be there, anticoagulation and antiplatelet also may have to be managed. There are obviously some challenges, but depending on patient, all these are actually variable. And if we see this picture, we can see patients who are having neither anemia nor transfusion, they have very low chance of complications. If patients have anemia, the complication rate will be more severe. If they have received transfusion, some complications are again less. If both anemia and transfusion are there, then again the complications are more pertaining to different diseases. Now, one can also see whether my patient require manipulation of dual antiplatelet or aspirin. So this is one simple tool. There may be many other tools. AI is also providing many tools now. So it will assess and give what is the risk of patient having bleeding. So maybe these kind of objective tools can also be used when we try to manage patients. So this is one more tool. There are like here actually there are multiple machines. So Verify Now is there, Multiplate is there, TEG is there, and ROTEM is also there. Even through ROTEM and Multiplate, actually we can know whether aspirin that we are giving, whether it is functioning, whether the platelets are resistant or they are okay. They are currently we are able to stop the platelet function. Similarly, in ROTEM and TEG also, there are different kinds of metrics. Like for example, ARATEM is which can be used for aspirin management, aspirin testing. There is ADP-TEM, there is again TRAP-TEM. So all these can be used for monitoring antiplatelet drugs also. And we were discussing about this also, the previous slides. So patients who are on aspirin, if it is emergency surgery, they can be proceeded to go for surgery. If it is urgent or elective case, if high risk of bleeding is there or patient is refusing blood transfusions, then aspirin may be stopped 4 days before surgery. If the patient is normal or has low bleeding risk, then aspirin can be continued. And dual antiplatelet therapy also, this has been discussed till now. This is one more protocol by European Journal of Cardiothoracic Surgeons. This is old strategy. So this has also been discussed by the previous speakers. Coming to intraoperative management, meticulous surgical hemostasis, autologous blood transfusion, especially acute normovolemic hemodilution, intra-op cell salvage, maybe using autologous priming also, ultrafiltration, heparin, protamine titration. So all these are some strategies that can help in reducing the intra-op bleeding. There are again different institutional algorithms that can be followed in the post-op period. As we can see, ROTEM is also part of it. Here also the same protocol. This is called cardiovascular A5 algorithm. So here also we try to first rule out hyperfibrinolysis. If it is ruled out, then we try to see whether heparin effect is there or not. Then we try to correct fibrinogen deficiency. If fibrinogen is deficient, then we try to give him fibrinogen complex concentrate or cryoprecipitate. Then this is followed by platelet requirement and generalized other factor deficiencies. We always try to give fibrinogen first because that is the factor that is first depleted in massive bleeding. And the other factor deficiencies can be rectified with FFP transfusion. The last is protamine overdose, where patient may require other drugs also. This is one more study, point of care hemostatic testing in cardiac surgery. Here we can see POCT guided transfusion management. This is from Germany. So it significantly decreased the odds of patient receiving allogenic blood products requiring re-exploration. Similarly, post-op acute kidney injury and thromboembolic events. So all these have been reduced, but no statistical differences were found in regard to hospital mortality, cerebrovascular accidents, or length of ICU stay and hospital stay during this study from Germany. So in the same study, what they have found is usage of ROTEM. It reduced somewhere around the total transfusions were reduced to 17%. FFP utilization was also reduced by 64%. Platelet utilization was reduced by 10%. There was potential reduction of up to 70% in acute renal failure, sepsis by 86%, thromboembolic events by 100%, and the composite adverse events were reduced by 79%. So when we should test with what, I think there are many protocols pertaining to this, but this is what the latest protocol or guidelines is. So we try to check not only with ACT after release of cross clamp, we try to do XTEM and FIBTEM also in ROTEM, and after administration of protamine to correct the heparinization, we also try to do INTEM and HEPTEM. So these two will help us in treating the patient better and giving what the patient may require. So depending upon the size of amplitude increase required in ROTEM, we try to increase the dose of fibrinogen and various drugs also, including platelets. This is just one example. Here in the first picture, we can see all the times are prolonged actually, CT, CFT, A5, A10. So this indicates actually residual heparin. Below HEPTEM is there. So in this actually heparinase will be used when we do ROTEM. So here it is normal. So it indicates that heparin is still more, so this patient will require protamine. And this is the normal patient, so both INTEM and HEPTEM are normal. And the last patient is actually protamine overdose. So again, we have to manage this patient with either FFP or APCC. And we have to remember that protamine is not vitamin P. This is one more algorithm. So if people don't have a ROTEM, if they have TEG also, we can use a similar algorithm. Before I go further, actually there is the massive transfusion, massive blood loss protocols. Now in the beginning of maybe 21st century, we have been thinking the requirement is maybe formula driven, 1:1:2 ratio. Then later on it became 1:1:1 massive transfusion protocol, wherein we try to give 1 red cell, 1 platelets, 1 FFP. Now it is more of ROTEM or TEG guided. We try to call it as goal directed blood transfusion. So if patient has some issue, we try to give only those components. For example, this is what we follow for plasma exchanges and red cell exchange. We try to do this at least 2 to 4 patients daily, and we follow this protocol. So if patient's hematocrit is, if the patient is losing somewhere around 30% of his blood, we try to correct it with red cell. It can be priming the machine, it can be anything. If patient is going to lose 1 volume of blood loss, then we try to correct PT and APTT with FFP when the INR is more than 1.5. If the patient is going for 1.5 units of blood loss, means the patient will be already continuously getting crystalloids and transfusions. So if patient has lost somewhere around 7.5 ml, then we try to give even cryoprecipitate. And platelet count, we try to administer whenever the platelet count falls less than 50,000. And this is only pertaining to what we can do. But when it comes to the blood banking part, there actually we have to see, there are again 3 kinds of transfusions. It can be elective, there is something called urgent, but both can be clubbed together, and there is emergency. So if a patient requires on emergency, what we do is we try to give, sometimes if we have time for blood grouping, pardon me for the mistake there. So if we have time for grouping, we try to give them group specific blood actually. Even without cross matching, we can give immediately group matched blood in a span of 5 minutes to casualty, it can be OTs. So this helps the patient in avoiding the hypovolemic shock and acute kidney injury that can happen because of hypoxia. And after we do this, we try to do cross match also, and we try to see that everything, all the routine procedures will go on. Sometimes there may be a situation wherein, for example, if you have a positive patient, I have seen somewhere around 140 units being transfused to patient in a single day. So if all the A positive units are gone, if all the O positive units are gone, we have even transfused B units also to A patients also, and patients have survived without any sequelae, because when these patients are having so severe blood loss, the antibodies that may be present in their plasma may have already gone out also because of the blood loss. So sometimes transfusion may be the first priority rather than anything else. And if patients are going for elective surgeries, then it is always better to be planned, better to do blood grouping than antibody screening. In UK and US, the basic protocol is to do blood grouping and typing and screening also. So all these help us in identifying patients who have some antibodies, so that if they require blood transfusion, we can be sure that we will be having some cross-match compatible units. Otherwise, in the end, if we want suddenly blood units which are compatible, it is difficult. And similarly for Bombay blood group, sometimes there will be patients who have multiple antibodies, like patients with sickle cell disease, thalassemia, maybe sickle cell disease with acute chest syndrome. Getting blood units for them is more difficult. Some of these patients have also been from Ramesh Hospital and all nearby hospitals. So similarly, managing patients who are already having some bleeding disorders or coagulation disorders requiring this is also difficult. Transfusion reactions are also there, and managing these is again, it depends on each center. There can be many possible reasons which can harm the patient, including improper storage, transport, appropriate transfusion. If we are transfusing something else other than normal saline with the blood units, it can also cause hemolysis. Usually we find all these as maybe simple jaundice after the patient has been transfused, maybe in 6 hours, sometimes even after 1 day, 2 days. So it's a tricky thing we have to go through. We have to see through and investigate, and all these have to be reported to Hemovigilance Cell of India. And in addition to this, we can also help in something called cardiac transplantation. We don't do cardiac transplantation, but we can help in HLA typing, high resolution also, low resolution also, donor specific antibody testing we do, finally active antibodies identification, single antigen bead, and other kinds of investigations to rule out the patients are not having antibodies directed to the donor units, especially the cadaveric things. We can do cross-matching also, and if antibodies are there and if we have to do transplantation, we do plasma exchange for these patients. And if you are if you are finding a patient who may require cardiac transplantation, then it is always better to get him transfused if he requires especially only leukoreduced blood units. It can be packed red cells, it can be platelets. And in addition to this, we also usually have blood centers licensed for stem cells. So we try to collect autologous units most often. I was involved in a study at SWIMS Tirupati, wherein we have done somewhere around 50 to 100 units of autologous stem cells. They were injected into intracoronary actually through angiogram. And there were many patients who were from abroad. They were receiving these and they had significant better ejection fraction after these stem cell injections. I think this is again coming up recently. So this we can help. And similarly, now it is also for heart failure patients. The market for this is also growing day by day. This is one place I wanted to show. First bloodless heart transplant in Asia. And in the future, as my previous speakers were telling, AI is on the rise, so medical management may be going slowly towards AI also. This is one doctor. The doctor actually emergency medical hologram. So in future, we may also have to take suggestions from them. Even if we don't take the Gen Z, immediately they take a screenshot of the case sheet which we may be writing. They will just ask AI in Google Lens, it will show. So we have to be prepared for this event also. Thank you all.
Thank you, Dr. Chaitanya.